But we'll go ahead and kick off with another legend in the spine field, Dr. Rhee.
All right, thanks and welcome everybody. So I'm going to talk about anterior cervical fusion and plating techniques. And ACDF is such a great operation. I dare say for the vast majority of us, it's one of the favorite things that we do in spine surgery because the outcomes are generally so good and patients tolerate it very well. But the truth of the matter is that it's an operation that's easy to do relatively poorly, and you get away with it because it's forgiving. But if you want to really decompress patients well and try to maximize deformity corrections and whatnot, then really careful attention to detail is important. So what I'd like to do in the next few minutes is to go over some of the finer points that hopefully can help you optimize this already great operation. So in 2024, the vast majority of ACDFs are plated, and for good reason. Plating has several proven benefits. First of all, it's been shown to reduce kyphosis. So in the old days, people used to do ACDs without fusion, or ACDF with a piece of iliac crest bone graft and no plate. And believe it or not, if you do 1 or 2 levels, the vast majority of the time, those will heal, probably about 70 to 80% of the time with a solid fusion. But the problem is they heal in this sort of segmental kyphosis. And initially, the patients do fine because you treated their radiculopathy. But what can happen over time is that even 1 to 2 levels of segmental kyphosis can lead to a global malalignment problem over time. So this is an example of a patient who had 2-level threaded cages many years ago. And if you're familiar with these cages, the way they gain purchase is by basically disrupting the end plates. And so if you do that, things are going to tend to settle in kyphosis, and over time, this patient unnecessarily developed a alignment that's suboptimal. On the other hand, plating can potentially improve alignment. This is a patient with myelopathy and a degenerative kyphosis that we treated with a 3-level ACDF to treat the myelopathy and also improve the alignment. The other benefit of plating is that if you use allograft or cages rather than iliac crest, which I don't think very few people use iliac crest nowadays, plating has been shown to lead to higher union rates as well. But I think as spine surgeons, we know almost better than anyone else that nothing is perfect, and certainly plating is not, and there's some downsides to it. It does add operative time. You have to retract the tissues more. It's associated with a range of swallowing complications from some minor dysphagia all the way up to a case like this where there was a chronic plate and screw back out causing esophageal perforation. If the plate is improperly placed at the time of surgery to be too close to the adjacent discs, or if the plate migrates into that position over time, you can get the so-called adjacent level ossification disease, or ALOD. And probably the most vexing thing is that despite plating, non-unions obviously still occur. So the act of plating itself is pretty simple. You just drill some holes and fill them with screws. But I would tell you that ACDF is an operation where each step really builds on the one before. And if you do a good job with the step before, the next step is easier. So it's really all the steps leading up to putting on the plate that I think determine the success of the operation. So in that regard, here are what I think are 7 important pre-plating and plating technical principles for you to consider. The first is during the exposure, perform a generous soft tissue release of all the fascial planes during the approach. That relaxes the incision, and I think it decreases the amount of force that you have to exert on the soft tissues during retraction, and so in my opinion, it leads to less dysphagia and dysphonia post-op. So, I know a lot of people just want to make an incision, stick their finger in there and get going, but I think a minute or 2 relaxing things, I think in many people can help. Once you get down to the spine, do a wide exposure of the longus colli that's longitudinally extensile to the mid portion of the bodies above and below the disc you're operating on, and then laterally you want to go beyond that upsloping portion of the uncus. And if you do that, it really serves 2 purposes. First of all, it gives you a stable cuff of muscle under which to put the retractors. And It also helps you center the implant and orient the decompression. You don't want it can be relatively easy, especially when you're first starting out, to get lost and kind of lose track of where the midline is, where the uncus is, et cetera. So a nice exposure, again, will build on the next step. The second important thing to consider is precision in your cast bar pin placement. So for reasons that I'll get into in a minute, that top end plate that I kind of drew out in yellow requires a little bit more preparation than the bottom one. So if you put that top cast bar pin too close, it'll get in the way and block the path of your instruments and make things harder to do. So you want that top pin in particular to be further away, kind of in the mid portion of the body or a little bit above. And that gives you an unobstructed line of sight to be able to do what you need to do in the back of the disc space, which, the vast majority of the time we're there to do a neurologic decompression. If patients have kyphosis, a well-known little trick is to place the pins kind of divergently into the kyphotic segment like that, so that when you apply distraction, then the distraction force gets converted into a lordotic moment. And the PLL can act as a pivot point for that correction. So this is an example of that technique in action. The patient with significant myelopathy, really bad disc degeneration, and a modest amount of kyphosis, about 40 degrees. And with this technique, going segment by segment, you can get a significant amount of correction. Here in this case, almost 50 degrees versus pre-op. The third important principle is to fashion what I call a rectangular disc space, consisting of parallel end plate surfaces. And that, again, serves two purposes. First of all, most grafts are flat. So if you have a flat surface that mates to a flat surface, you're going to maximize the graft-host contact area. And also, if you do that, again, it allows you to get a good look at the back of the disc space so you can do a nice decompression. When you're doing this, keep in mind the anatomy of the end plates, and this is what I was alluding to earlier, is that, and I guarantee you of this, in every cervical case you ever see from the rest of your life, from now to the rest of your life, you will find that the top end plate has a concavity to some extent. Now, the more degenerative the level is, it will tend to flatten out, but there's always a concavity. You can see that in yellow there, whereas the bottom end plate in blue tends to be flat. So when you create this rectangular end plate preparation, you want to resect the bone in the anterior and posterior lips off of that top end plate and preserve the central portion of the top end plate and all of the bottom end plate for weight bearing and structural load purposes. The fourth principle is then to do a very wide discectomy, and that serves several purposes as well. Number one, it facilitates a wide decompression of the posterior aspect of the disc space. It also loosens up the disc. And so what it allows you to do is to get better height and lordosis restoration. And then finally, of course, you can place a larger graft, which means better bone-host contact and maybe better fusion and better biomechanical properties. Now, the uncus is the key anatomic landmark for all of anterior cervical spine surgery because it defines what I would call the effective and the safe zones for this operation. It's the effective zone because, barring just a few anomalies, if you have done an uncus to uncus decompression at the level of the disc, you will have decompressed the entire width of the spinal cord. And it's also the effective zone because it defines where the proximal root is going to start taking off. But it's also the safe zone, of course, because somewhere around 5 to 10 millimeters lateral to it is going to be the vertebral artery. So it's the guardrail for the vert. Now, the vert is typically in about the mid-third of the depth of the disc space, but it's highly variable, not only from person to person, but from side to side in the same patient and from level to level. So one of the most important things you should do always before you scrub in on an ACDF is to make sure you know exactly where the vert is at the levels that you're operating on. So the discectomy should be wide from uncus to decompress the cord. And then, of course, you go out further laterally to decompress the foramina as needed. The fifth principle is then to try to fill the disc space with as large a graft as possible for better load sharing and fusion. So In the old days, I used to use allograft, and most of these are commercially available as 14 by 11 millimeters. And they're fairly small. So what ends up happening is in a large disc space, for example, C6-7, especially in male patients, if you put one of those in, it doesn't fill the disc space very well. So what I used to do is take 2 of those and turn them side by side and do that sort of thing. And it works well, but it's a little finicky, and sometimes you can't get both of them to fit just perfectly. But here you can see the clinical example of what the grafts look like when they're rotated 90 degrees. But currently, what I prefer to use are sort of these large footprint lordotic cages, because I think they better load share and they're going to settle less. And we published a paper fairly recently showing that these large footprint cages have less settling, but similar clinical outcomes in fusion rates. So if you look at the amount of segmental lordosis at the operative level versus pre-op, these cages will generate about 6 degrees of lordosis per level on post-op day 1, and by 1 year, the vast majority of that's been maintained. They still have 5.8 degrees of correction versus pre-op. If you use allograft, you initially get a similar amount of correction, about 5.6 degrees, but over a year, it tends to settle, and as it does, you lose almost 50% of the initial correction you had. So this is a patient with a modest kyphosis and myelopathy that was treated with this approach. And those are the 1-year x-rays, and you can see the correction's been maintained. The next step is then to determine plate length. You want to know the location of the discs above and below so that you don't injure them with an errant screw or drill or something like that. And once you know that, you want to pick the shortest plate possible that spans the construct. Because if you do, it allows you to place these diverging screws that can optimize strength and also optimize length and pull out strength. And it will also best accommodate settling. So we talked about ALOD, remember the adjacent level ossification disease. As the construct settles, if you have a smaller plate, it's less likely to impinge upon the adjacent levels. So here's an example of that, a patient that had an ACDF where you tried to keep the plate as far away from the adjacent discs as possible. And then the final step is to apply the plate, and in the sagittal plane, you want to spend a little time removing the anterior osteophytes to allow the plate to sit flush. Usually just take a Lexel and kind of garden that off before you even do the discectomy. And I bend lordosis into almost every plate. The plates come pre-bent, but usually they're not bent enough. And then you want to optimize the screw length. So this is an example of the old Caspar plate, which was meant to be bicortical. There was no back-out mechanism, so you're supposed to put in bicortical screws. But you can see a couple of these screws are just way too long. On the other hand, if you go too short, maybe you're not optimizing the biomechanical strength. So I try to get bicortical fixation as much as reasonably possible. It's not always perfect, but I do think that perhaps that may have some benefit in terms of fusion rate and outcomes. So with that, I look forward to working with you in the lab on these techniques and trying them out. Thank you. And then who uses a rigid fixed plate? Fixed screws at every level?
If I'm doing like a deformity correction or whatnot, I don't want it to move, so I do that. If there are some times that you may want a bit of subsidence, particularly if you're over distracting of like 1 or 2 level collapsed disc. But in general, I use fixed screws and whatnot for trauma, for deformity.
What about like a standard degen case, like a 2-level radiculopathy or something?
Again, I think a little of it is, what I'm a little concerned about is if you over distract the facet joints and you put a fixed screw in, you're going to have the bone subside around the screw. So if I got something that's really collapsed down, I will use variable screws. Mm-hmm. If it's something that I want it to stay in the position where I am, exactly to your point, that I'm putting a very big, fully filling the end plate interbody graft, and then hopefully locking that into position. But fixed more than variable.
And who uses completely variable screws? Anybody? The rest of you use like hybrid, fixed and variable?
I
Is
use
that right?
variable. If it's trauma or it's deformity, then I'll use fixed, but everything else is variable.
Yeah. I generally use like hybrid. I kind of use fixed screws up at the top. And then at the bottom level, I use variable because I know that's the level that needs a little bit of settling and the one that typically doesn't heal as well.
How did
so
you come
that's
up
what
with
I
that?
do.
Because when the Atlantis plate came out, and those guys were all saying, put your fixed screws at the bottom.
Oh, okay. I always found that the bottom level, to me, it made more sense that that level needs to subside just a little bit. And also because you have more room from the bottom of the plate to the next level, you don't worry as much about the plate overlapping the next disc level. So that's why I do it that way. Yes?
Now that you've kind of transitioned to cages over allograft, do you think the fixed versus variable angle kind of, it changed your management, the utilization of either of those screws, I guess?
No, it didn't really change my management, but I do think that whether it's the cage or the size of the cage versus allograft, they subside less, in my opinion. And also because bone, as it heals, it resorbs, right? Whereas the cages aren't going to resorb. So then you worry about, is there a difference in fusion rate? But at least in the series that I did, it didn't seem to make a difference.
All right, so this is a posterior cervical laminoforaminotomy. So a couple disclosures which aren't relevant to this. So when we do laminoforaminotomies, that can be done either as part of our posterior decompression if we're doing a laminectomy or a laminectomy infusion, or even as part of a laminoplasty. Or it can be done isolated. So it can be used in a variety, but here we're going to talk about it as a standalone, just doing a posterior foraminotomy in terms of the surgical technique. And I want to just review a little bit the anatomy of what your goals are for doing the laminoforaminotomy. We'll go through some pathophysiology, some indications, and then have some videos for the surgical technique, et cetera. So obviously the neuroforamen is bounded by the facet in the back, and then we have the edge of the disc space and uncovertebral joint with the vertebral artery right here. So this is what we're trying to decompress. And if we look at it on the lateral view, you can see it's really bounded. For the nerve root coming out here, the structure right on top of it is the leading edge of the superior facet. That's ultimately is what we're going to have to remove to decompress that nerve root, bearing in mind the relationship to the vertebral artery. It's also important to remember that this height of the foramen is dependent on the height of the disc. So as the disc degenerates, that three-dimensional volume of the foramen is similarly going to shrink. And that's going to lead to a relative contraindications when that disc space is relatively collapsed. Doing a foraminotomy, you're not able to restore that the rostrocaudal dimensions of that foramen, and that might be where an anterior approach might be better. So it's really that everything's going to hinge on our access to that superior articular process there. So what are the indications, or what can affect that nerve root in the foramen? I think most commonly it's going to be a disc herniation or marginal osteophyte, which is going to compress on the nerve root in this location. Obviously, this is a very common pathology for all of us, but just seeing that disc coming out and it's impinging on that nerve root right in the foramen, this would be a great candidate for a foraminotomy. With the marginal osteophytes, if you're getting your oblique x-rays, you can see here, you can see the spurs coming in, narrowing in that foramen. And you can see that on the axial CT there, that those are spurs coming back and really digging into that foramen. You can have the foraminal stenosis from significant facet arthropathy. So this is a very enlarged facet. You can see on the axial CT how enlarged that facet is, and you can see the anterior spur coming off that articular process, digging into the foramen. Or you can have a synovial cyst. And these, I'm at least in my healthcare system, this seems to be missed by radiologists more often than not. They will say there's no pathology, and you can look and you'll see a small synovial cyst. Typically at C7T1, you'll see this little white cyst there into the foramen. You'll see it in this corner here. I'm always surprised at times where someone has clearly a C8 radiculopathy, the MRI is read as normal, but you can really see these cysts in that location. Happens at more at C7T1 than other levels. So what are the indications for doing a foraminotomy versus an ACDF? If it's compression of the nerve root in the lateral recess of foramen, soft disc I think is a great indication. Facet arthropathy is a great indication. Synovial cyst is a great indication. Marginal osteophytes is a little bit harder because it's hard to remove those osteophytes on the other side of the nerve from this approach. I would say those should be better treated anteriorly. And a relative contraindication, as we talked about a minute ago, is that there's a significant loss of disc height. If you're just decompressing the foramen, you may not completely decompress that nerve root because you haven't restored that rostrocaudal dimensions of the foramen. There's some contraindications to doing this. If there's instability, whether spondylolisthesis or dynamic instability, if there's excessive angular motion, a lot of neck pain, if they have deformity or kyphosis, or if you have to remove more than half of the facet. And that came out from paper by Tom Zadeblik way back in the early 90s, doing cadaveric studies showing with how much facet would you have to resect before you start seeing any segmental instability. They didn't see any change in stiffness with resecting 25 or 50% of the facet, but they did see significant decrease in stiffness resecting more than that. So their conclusion is if you have to remove more than 50% of the facet, that's going to put this patient at risk for instability. So that's just a general rule of thumb. So what's the surgical technique? There's a lot of varieties of how to do this. You could do them in the sitting position. At our hospitals, our healthcare system, the anesthesiologist largely will block any attempts to do a patient in the sitting position. But it used to be a good procedure for it. So I do them prone. I typically put patients in a Mayfield head holder. I put their neck slightly flexed just to help my access there. I think the microscope's very helpful here, is you're doing either through either doing it open with a small incision, a small retractor, or tubular or endoscopic, but you need to have some visualization both for light and for magnification. I think Chris, in your talk on ACDFs yesterday, you're saying for all your posterior foraminotomies, you would use a scope, if I heard that correctly.
I just think it's to separate. You get it there and everything's inflamed, and I just can't see well enough to see. You don't want to stick your 11 blade into the nerve root when you're trying to pop into the disc.
True. All right, so just again, looking at the anatomic structures we're trying to address. So obviously if we take the spinal cord and nerve roots, and we think about where the pedicle is and the exiting pass of that nerve root, we're trying to get to the nerve root right here underneath the facet joint. So if we look at that from the side, you can see, if we do a magnification of that, here's the nerve root underneath here. To get to this nerve root coming out here, this one here, it's the superior articular facet, which is right over it, but we're going to have to remove some of the inferior facet joint to get to that. So typically you're starting off with the medial 50% of the inferior facet to expose the superior facet, and then you're going to drill the medial 50% of the superior facet to expose the nerve. There's a couple different approaches in terms of what your quarter is going to be, whether you're coming at the spine, like in this illustration where you're coming more from a lateral to medial approach, or this illustration where you're coming more from a medial to lateral approach. It really depends on which pathology you're trying to address. So for example, if we do come in more straight, you're having better exposure of the lateral recess to do that. And in this case, I'll stand on the same side as the decompression, and we're coming straight down. If I'm trying to get further out into the frame and we really want more of that medial to lateral approach, and you may want to stand on the opposite side of the patient to get there, this will get you further out into the frame, and it also protects a little bit more of that inferior facet because you're working really underneath it. So to visualize this, I have both a 3D animation and then I have an operative video, both donated by other people. So this was my old partner, Paul Santiago, is now at University of Missouri-Columbia. This is just a nice 3D animation that he put together for a tubular approach for foraminotomy. So you're docking then on that, essentially the inferior facet, putting your tubes down. So what we're looking at this is the inferior facet, the superior facet. Here's the medial border, so here's the the edge of the spinal canal there. So removing the medial portion of that inferior facet to then visualize the superior facet, removing that as well as some of the leading edge of the lamina here to expose the nerve root going out. And then depending on what the pathology is elevating that nerve root to access the disc space underneath. So there's a couple tips and tricks. You really want to have a lot of irrigation while you're doing this. So we had that discussion yesterday about how especially with the diamond burr, but really with any drill, you're generating a lot of heat. And you're drilling ultimately right next to this nerve. You need to keep that drill cooled, so it's copious irrigation. This tends to bleed quite a bit, but you'll stop periodically, just put a little wax on your edges that will dry it up and you keep going. I typically will eggshell the superior facet over the nerve, try not to go completely through the cortical shell of that with the drill, and then come under it with a small up-angled curette, and you can usually flick off that last little pieces of bone. You don't want to introduce any instruments into the frame until you have it fairly well decompressed, just to avoid any nerve trauma. If you're trying to stick a kerrison in there to do your first few bites, the heel of that kerrison is really going to be digging into the nerve root. And then just confirming your decompression with a small probe. So this is then courtesy of Dr. Patel, who gave this to me for the talk last year. So this is an operative video. So just to orient people, the head is up here, midline, lateral. So this is going to be the inferior facet, and this will be the superior facet. So it's again, you're initially removing that medial portion of that inferior facet right at the medial border with the spinal canal. And then it's drilling just a little bit of that superior facet to expose the nerve. And you can see next you'll come in with a small curette just to take off that last few pieces of bone. So as you've eggshelled it down, you can usually just crack these off and away from the nerve and then remove them. It's a very atraumatic way to decompress the nerve. Then this was the indication for a soft disc herniation, so reaching underneath with a small probe, and then he's going to be able to deliver a pretty impressive piece of disc out of the axilla of the nerve root. It gets better. There's more coming. So this was a very satisfying video to watch. It's just a big disc underneath there. So what are the potential?
My fellow said that felt like my fellow was a case study. He's like, that's better than watching Dr. Pimple Popper.
Yes. I don't think they're usually that satisfying. Usually it's very small pieces of disc. So what are the complications from this approach? You're right on top of the nerve. Potentially you could have a nerve injury, nerve palsy. That's being careful not to deliver excess heat to the nerve, and be careful not to traumatize the nerve by introducing instruments into the frame prematurely. CSF leak would be fairly rare chances of delayed instability or deformity or persistent radicular symptoms. I think the persistent radicular symptoms, that's typically when that patient has a significant collapse of the disc space and you can't quite get that nerve completely decompressed just by unroofing it. What are some of the reported complications? So Shiraz Qureshi had reported on their 70 patients, followed about almost 3 years. Small, one CSF leak, one hematoma. A small number of these patients ultimately required an ACDF. Chris, this is yours from 2009. They're following 162 patients out 5 years. Small number had a persistent radiculopathy. Small number had developed an instability, one requiring surgery. So a very small number had a postoperative deformity requiring surgery. So it's a very low complication rate. Looking at this was again Shiraz Qureshi, looking at the difference between doing this open versus minimally invasive. Really, it was dealer's choice. The clinical results are equivalent. So it's really however you want to access it. I think this is an excellent operative technique for the right indication. This is often done, as we said at the beginning, often done as an adjunct to other things you're doing. So if you're doing a decompression for myelopathy and they have a radiculopathy of one nerve root, you can always add this into the operation you're doing and just do a foraminotomy in addition to other surgeries, but is also a great operation on its own and has a very low complication profile. So thank you.
That was great. Thanks, Neil. Any questions for Dr. Wright?
We have one in the back.
Great talk, thank you. Any tips on localization of the lower down?
Yeah, I mean, I think that's true for anything you're doing in the posterior cervical spine. Is often the shoulders will get in the way and becomes. I probably give people a lot of labral tears by pulling on their shoulders so much to try to get that visualization. Between AP and lateral fluoroscopy, if you're trying to do this lower, sometimes if it's someone's really obese, there's a couple options. You can either make a bigger incision to start with, so you can clearly identify a level on the fluoro and then just be able to determine what segments below that to go to. Other options, I haven't seen this so much for cervical, but for upper thoracic, you can have radiology put in a marker in the spinous process or something like that, which would show up on x-ray. But it's going to be a challenge on the obese patient in the lower cervical spine. I always, in that situation, usually consent the patient that there is a small risk of operating at the wrong level just because of those factors. Doesn't get you out of trouble, but.
Or you can use no arm. That's what we do now. Just have your arm ready. You're doing C17.
It's a great idea.
An AP fluoro image, right? You can usually see the first rib and go up from there, as long as it's consistent with the pre-op done right.
Yeah. I think it gives you a high level of confidence. I'm not as assured of my being at the right level with an AP. But
The AP's got to be straight. I mean, you start angling it and you can fool you.
Like an orthogonal AP.
I will tell you, if you don't have an ACDF plate or something to counter off of when you're looking at your levels, putting a needle in, and if you're doing 7-1 or lower, and then you do the O-arm spin, keep that needle in above so you can use it as a point of reference for your x-ray. So even, because you don't want to come back in and do a second spin or a second, it's just it's more radiation than needed. So just leave that needle up a little bit higher so you can reference it with a lateral x-ray. Usually like at 5-6, so I can see that relatively easily. And then I'll continue like because you're gonna dock your tube, and then you got am I down on it? I don't know. It's hard to see. At least you have some point of reference off that needle as you cone in your C-arm.
All right, we'll move to arthroplasty, which is my charge this morning. And so we all know we had an excellent talk on ACTF technique. We all know developed in the 50s and has been our gold standard and really still the workhorse of what we do in the cervical spine. Fusion rates are excellent. You lose one motion segment, the others compensate, so global motion doesn't change, but you do start to lose some global motion as you do more and more segments. And so that's, and also, I believe that prior to arthroplasty, we never really knew for sure how much fusion pushed the limit and aggravated the adjacent segments, because the Hillebrand paper is very contradictory. The more levels you fuse, the less adjacent segments, so why would that be biomechanical? And so we didn't really know, but I think I'll show you some data that we know this now. And we do know in the lab discs adjacent to fusions have increased pressure and some different biomechanics. A lot of people worked on this. I'll just show you this for historical reference, the famous Fernstrom balls, which didn't last for long for obvious reasons. These things spit out, subsided, but an interesting concept. And nothing really happened until the late 90s, and it occurred in England. Mr. Cummins designed this crude device in the hospital foundry and started implanting it, and that was kind of a big beginning, and then Steve Gill advanced on that, all at this French hospital. And it led to the first approved disc in the US, the Prestige ST, but that was shortly followed by ProDisc and the Bryan. And so if we look at what's available, this is what I call the first wave, and ST is no longer available, the Bryan is no longer available, ProDisc is kind of wavering and bouncing around. So then what I say, the second generation Secure C, Mobi-C, Prestige LP, and then more recent comers, M6 and Simplify. And they're all a little different in their construction and a little different in how they articulate and what they do in the spine. It's important to know that these are the only discs currently approved for 2-level. So when you get out and you want to put something else in, it's a 2-level, you're going to almost universally get insurance denial. You're going to have to use one of the approved discs for multi-level. Like anything else we do, patient selection is the most important. I think it's critical to try to put the disc in precisely, but I can tell you I was an overall PI on one of the national studies, and I started looking at x-rays, and the discs were put in all kinds of sideways, off to one way, angled, and I was very concerned. So I pulled out some of the worst x-rays, and I got the patient outcome data, and it was excellent. And so I think the message is, for most of these devices are pretty forgiving. So you need to, I'm not telling you just slop it in there. Strive for perfection. But if you get some x-rays that don't look just quite as nice as you'd like them to, don't fret. It'll probably be okay. Other problems, there can be some operative issues. If it's a small person, the disc may be just too big and you're going to overstuff it. You may violate the end plate, things you may have to deal with during surgery. Initially, heterotopic ossification was a bigger problem, particularly with the Pro-Disc C, but it's less of an issue now, and most surgeons use non-steroidals for a month or so after surgery to help minimize that possibility. So patient selection. Here's a patient. You're not going to put, most people are not going to put arthroplasty, multi-level arthroplasty in this patient. And with the fusion, you can increase lordosis, you can decompress. And so it's more front-end disease by and large, especially if you're just starting out. There are people that are pushing the envelope, and I'm going to get to that. But if it's really a multi-level, a lot of collapse, this is what you need for the fusion. And this would be perfect. A big fat disc here is what we would like, but somewhat rare. What are the long-term outcomes? We did this study looking at all the IDE studies in the US as well as a couple Chinese RCTs and tried to figure out what happens with these. Because at the 2-year data, with every single study done, you could blind anyone to the fusion arthroplasty patient and they were all the same. Maybe the arthroplasty patients went back to work a little quicker, but pretty much the same. And what happens is really, if you follow them long enough, there's a break point at 5 years. And at 5 years, we know there's more surgery in the fusion patients. And these are the data I said are convincing that fusion does push it along a little bit. So here's pooled results. Adjacent levels, need for adjacent level surgery, single site, and the boxes are the arthrodesis patients. This is the index level. Arthrodesis patients need more surgery at the index level. And again, it splits at 5 years. And I think something happens around 5 years. Part of it is maybe our aging process. Because these are data from the Prestige ST study. And if you look at the implant, somewhere around 5 years, it loses a degree of motion, which is just a degree, but percentage-wise, it took a pretty big dip. So I think it's part of the aging process that leads these other segments to go. And we also see a little more stiffening at the index level. The data are the same for 2 levels. More surgery as time goes on with the fusion. So, and there's all kinds of forest plots we can make showing that it's helpful. And it's really skyrocketed. The use of discs has really taken off. And so I do believe in the right patient, this is a better operation. It's a better long-term operation. And I'm a big fan of lateral disc. That was a beautiful lateral disc you took out. If it's way lateral, I'm going to do a foraminotomy and a lateral disc. But anything short of that, if I think they could qualify for an arthroplasty, that's what we'll look for. Now, I used to say, and I spoke many times about follow the IDE study recommendations and you will replicate the results. And I believe that. But even myself, I started pushing it out. And I think we can push it farther. So here's a patient. I did a foraminotomy on him in 2009. Did fine. Comes back many years later. Arm pain. And here's his radiographs. I mean, his MR. He has symptomatic 2-level disease. Here's his x-rays. And I wouldn't have put this
patient in the 2-level study. I think if we measured the disc space collapse, the osteophyte formation, I probably wouldn't. And so, but I decided maybe he would work, and we put in 2-level disc replacement, kept motion, and he did fine. And so more and more myself and I see almost everyone putting in discs pushing the envelope a little bit. This is not an IDE study type patient. And I think that it's okay. We just have to be cautious not to really overdo it. So here's, we know that has a cost advantage over ACDF, and it's mostly due to the long-term follow-up, where as the years go by, the need for more surgery really drives up the cost. As I mentioned earlier, HO really more of a minor issue. Now, what about really pushing the envelope? How about 3 levels, 4 levels, 5 levels? There are now people doing this. Here's Matt Gornet's paper on 3 and 4 levels, and there's a lot of disc replacement in these patients. And these talk about some problems with them, but overall, it's an article that implies the results are pretty good. I have myself reoperated on a 4-level disc replacement that actually looked outstanding for 6 months, and then the whole thing fell apart. And I don't know if that's just an outlier or what, but there are people doing this, and you're going to see it, and it could be maybe someday this is what we're all going to do. So this is the future. And then what about adjacent to a fusion? It's a popular technique in Europe. A study's been done. It doesn't matter if the disc is above the fusion or below the fusion. So if you're going to choose, you don't have to worry about that. And it's a little hard to get approved in the US. So I'll tell you what I do is every patient, if I want to do a hybrid, I book it as a 2-level arthroplasty. And in my operative note, there'll be something that happened at one of those levels that it had to convert it to a fusion. And the other thing I do is I make sure that the first thing I put in the op note was the arthroplasty, because you're allowed to put a fusion next to an arthroplasty. And if I say I did a fusion, I don't want them coming back and saying, okay, you did that fusion, you shouldn't have put the disc in. So I have my own little game, but you can kind of beat the system if you want to do it. And I do think it's an excellent procedure for a number of patients. What about adjacent to lots of fusions? Well, this is original Bristol disc, and they only put it in what they called end-stage patients after there was a long fusion. And it worked well. There's a 17-year follow-up paper, and these things were still moving as crude as they were. And so now we're seeing more and more, also, this is mostly coming from Asia, large fusions with discs next to them, all sorts of variations in hybrids. And I think this will continue as well as time goes by. So my advice to you taking the course, start with just the IDE indications. Learn the device you're using. Know how mobile it is, how mobile it isn't. Make sure you understand it. And once you gain experience with it, then you can start to push the limits and step out a little bit. And I don't know what devices we have here, but there's certainly a couple you can. And you need to know the implant techniques for whatever device you're using. They're similar, but not quite, and you want to try to be precise and know what to do. And with that, I thank you for your attention. If I do what?
Use HO prophylaxis?
I ask my patients to take Advil for a month, 2 in the morning, 2 at dinner.
So how about in patients where you're doing a hybrid procedure?
I don't. And I hate NSAIDs. I don't want Toradol. I mean, I know we were given Decadron early for dysphagia. I don't even do that. They're getting nowhere near anti-inflammatories if they're having multi-level fusion, and so I don't use it then.
So then, so that becomes my question with cervical disc replacement. If we're not using it in the hybrids, are we actually worried about HO? Like, I just get a little concerned in the future if I do it. Like, what?
I'm not. I think the Protis C was maybe others can comment. It really was a high HO device, and in the ST study there was not a single case, but that had that flange. In the LP study, 1 case of HO. Actually, it happened to be an implant I put in, and so And the same with the Simplify, all of these Mobi-C. HO just seems like it's not a big deal anymore. At least, you guys have trouble with HO? Rick? You put a lot of disc in.
HO is funny. I do believe that non-steroidals decrease the incidence of HO, but there's some, we're actually looking, one of our fellows or residents is looking up we've been involved in all sorts of IDE trials, and there may be some device-specific issues that may increase the incidence of HO. But we don't know. The one thing we do know about HO, it doesn't affect clinical outcomes.
If these things lose their motion and views, and it's going to happen, just like you get non-unions, it's great because it's still a fusion, and they still do great. So, unlike a non-union.
Any other questions?
One more.
Adjacent segment disease above or below what is your go-to?
If it would qualify for another disc, there's good motion, it's not overly collapsed, the facets are not arthritic, I would put another arthroplasty in.
Let's say it is collapsed. Fusion above that or below?
I don't have a problem doing a fusion next to arthroplasty above or below, but again, if it looks like it would fit, Rick, one of my partners, Rick Fessler, has a patient, he put a Bryan disc in the study. Bryan, and about 3 years later, they got adjacent segment disease, he put another Bryan in. And this patient now has 4 Bryans in, and is doing fine. But they all went in one at a time, stretched out over a number of years. So that patient probably didn't benefit from the disc. It still got adjacent segment disease.
I have one quick question. Cervical facet arthropathy is a contraindication. I CT everyone. I'm not sure that's necessary. How do you evaluate posterior cervical facet arthropathy as a contraindication of disc replacement?
That's a good comment. Ron Lehman used to talk about CTing everybody. If I look at them I can get some assessment of the joint on the MR. Certainly if there's fluid, if it looks a little enlarged, I look at plain radiographs, and I'm more selective because it's just to radiate them just to see. And also, if it's a radiculopathy or a myelopathy and they don't really have a lot of neck pain, I'm not worried about the joints. The patients I don't want to put a disc in, if their problem started with trauma, I've used them all. I think something happened. And so if you tell me this started with some kind of trauma, I'm going to fuse you. I'm going to find a reason to fuse you. And if I am worried about the facets, if I'm worried that much, rather than get a CT, I'd probably just fuse them. Say, I didn't like the way your facet is. So I don't use it that much, the bottom line.
I've been asked to talk about cervical PSOs for chin-on-chest kyphotic deformity, and these are very powerful operations with the ability to significantly correct deformity. What was that line from Spider-Man? With great power comes great responsibility, right? So they carry significant risk, and so we need to be careful when indicating and doing these procedures. So what are the indications for a cervical PSO? Well, number one, it should be a severe fused kyphotic deformity of the cervical spine. And it should be severe because PSO has the potential for significant morbidity. So if they don't have a severe problem to start with, then I would argue probably the juice is not worth the squeeze. Often these are big surgeries that are done in sometimes frail, compromised hosts. So in that regard, this is a classic paper by Ed Simmons and his son, Ed Simmons Jr., entitled 36 Years of Experience of Cervical Extension, Osteotomy, and Ankylosing Spondylitis. And they had a large number of patients, 131 with 2-year follow-up. And just to be clear, these were not PSOs, but they were 3-column osteotomies. And what they did is a posterior column osteotomy with an anterior osteoclasis. So basically, the technique involved a wide laminectomy, total facetectomy, and then the surgeon would grab the halo and crack the head back and basically get an anterior osteoclasis. So what you can see mechanically when you do this operation is that the posterior column shortens, which is generally good for neurologic preservation, but the anterior column lengthens, right? It kind of fish mouths open. So that can potentially have consequences on lengthening some of the soft tissue structures in the anterior part of the neck, like the esophagus, blood vessels, etc. So this is from the paper. He did them awake under local anesthesia so that you could have, kind of the best quality neuromonitoring, right? This was before the days of reliable neuromonitoring. He would sit them in a dental chair. As I mentioned, the wide laminectomy and facetectomy and foraminotomies of the exiting root. And then I love the description. The surgeon grasps the halo securely and brings the neck gradually into an extended position posteriorly as osteoclasis occurs anteriorly. And an audible snap and sensation of osteoclasis are usually noted. So there was no internal fixation. All these patients were treated in a halo for 4 months. Sounds like fun, right? And then a SOMI after that for 2 months. So 6 months of fairly cumbersome external immobilization. It's very old school, obviously, but you could see he had some very impressive results clinically. And if you look at the data, you can get about 50 to 60 degrees of correction in their series. You actually get a lot more correction from this than you do from a PSO because you're just fish-mouthing open the anterior column. And then neurologically, there were some interesting things that they noted. There was one patient who had intraop paraplegia, but they thought it was due to the dura buckling so much that it was compressing the cord, so they did duroplasty and it actually resolved. One patient became paraplegic and couldn't walk. One patient had hemiplegia due to a carotid artery distraction injury resulting in a stroke. So again, that relates to that lengthening of the anterior soft tissue structures. And 18 patients had a transient C8 radiculopathy, and that's probably the most common neurologic complication that you'll see with a cervical PSO. And by the way, there were 4 deaths as well, 3%. If you look at the modern PSO literature more broadly, and the neurologic complication rate. The studies are hard to compare. They're kind of all over the place. But if you kind of average it out, there's probably about a 25% rate of neurologic complications post-op after a cervical PSO. Thankfully, most of these are transient C8 palsies rather than being like a spinal cord injury. But if you imagine, not having C8 function, that has a big effect on the ability for you to use your hand. If you look at other series of adult cervical deformity, not necessarily osteotomies, but patient with cervical deformity, like this one of 78 patients, they found an overall early complication rate of 44%. And 28% of these patients had at least one minor complication, 24% had one major, and 1.3% risk of death. So the deformity should be severe, but in addition, it should also be fused. And my general rule for any kind of deformity correction, whether it be thoracolumbar or cervical, is that if there are available non-fused motion segments, generally it's a good idea to use them to gain correction. In other words, just because you know that a PSO can get you 35 degrees and the patient needs 30 degrees, doesn't mean that's the operation you should go to, obviously, right off the bat. So here's an example of a case like that. 53-year-old man. He had a chin-on-chest deformity, and he also had myelopathy. And this was a case of a dropped head syndrome due to idiopathic neck extensor myopathy. And if you look, he has open, unfused disc spaces. The deformity is pretty rigid, but it's not fused. And so you can exploit those open disc segments through a multi-level ACDF and then a posterior fusion. And this is what the guy looked like post-operatively without doing any kind of osteotomies. So in terms of the technique for a PSO, basically what you do in the first part is a very wide laminectomy of the level that you're going to do the osteotomy as well as above and below. Then you take out the facet joints above and below the level of the osteotomy. At that point, you then enter into the vertebral body and remove about the posterior 2/3 of the body. Once you've done that, take out the pedicles, dissect the plane between the dura and the posterior vertebral body wall and implode that in away from the dura. And then the final step is to take a wedge out of the lateral cortical margins of the vertebral body. And then at that point, you can add a corrective force, either extension through the neck or through instrumentation, and/or through instrumentation, and get osteotomy closure. So you can see with the PSO in comparison to the other osteotomy that I showed you, the posterior column shortens like it did there, but the anterior column remains unchanged. And so this is inherently a little bit more biomechanically stable than a Smith-Peterson type or a posterior column osteotomy with anterior osteoclasis. And in general, the literature suggests you can get around 30 to 35, 40 degrees of correction per level. So here are some cases. This is a patient that was 63 years old. He came to me after 15 previous cervical spine operations, if you can believe that or not. And he was fused solid in kyphosis from C1 to C7. And I did a C7 PSO and got him like this. And actually, intraoperatively, we got him a little bit better, but every time I extended him a little bit more, the signals got a little bit iffy, so this is what we accepted. And you can see on the post-op CT scan, that's the C7. C7 is right here. There was this very large anterior cortical thickening in this patient already, which was very helpful because that's sort of the strut that keeps the anterior column from collapsing as you do the deformity correction. So the question often comes up as to what level should you do the PSO, and classically it was done at C7 because there's typically no vertebral artery at C7, although maybe 5 to 10% of people do have one at C7, so you need to watch out for that. But C7 is also an intrinsically mobile area, and it's a small vertebral artery body. And so when you do the osteotomy, there's less kind of work you have to do because you're working on a smaller piece of bone. The downside, though, as we mentioned, though, is that C8 palsy is common. And this is probably related to tension and drift back. And about 30% of patients develop some sort of hand weakness, at least transiently. So the alternative is to do the osteotomy in the upper thoracic spine. And if you want to try to avoid any effect on hand function, you might decide to do it at T2. The other benefit of upper thoracic is that the vertebrae are taller, right? So if you have a taller vertebra and you take a wedge out of it, geometrically you're going to get more correction than out of a shorter vertebra. And you're going to also have good pedicle screws above and below. So it's more secure fixation across the osteotomy. You can use those screws for deformity correction as well. But the downside is that you have to take out the rib. It's more work. It's a bigger vertebrae. Intrinsically, this is a less flexible area of the body. And it may be far from the apex of the deformity. So if you have a cervical deformity and you do something in the upper thoracic spine, you also have to probably carry the instrumentation down even further as well. So like everything, there's trade-offs. But here's an example of a PSO that was done at an alternative level. And sometimes you have to just kind of do what seems to make sense. So 68-year-old woman who was sent to me after multiple anterior-posterior surgeries done elsewhere. She had myeloradiculopathy, and her other chief complaint was that she had trouble holding her head up. And if you examine her, her chin wasn't completely on her chest, but it was pretty close. I called it chin near chest. It was a very stiff, non-reducible kyphosis, but she had a normal neurologic exam. The MRI showed residual cord compression at C3-4 and a spondylolisthesis at T1, T2 with severe bilateral foraminal stenosis. And the patient described sort of what she called electric shocks down her arm, which I thought was related to the foraminal stenosis. And on the axial cuts, you can see there's residual cord compression at C3-4. It's moderately tight at C6-7, and at T1, T2, where there's the severe, where there was spondylolisthesis, there's severe cord compression. On the CAT scan, really bad C1-2 arthritis on the right side. You can see here that the patient had residual OPLL, so I suspect the treating surgeon probably didn't recognize this pre-op, got in there and saw all this stuff and just put the cage in and called it a day. But fairly significant residual OPLL, and she's solidly fused from C3 down to C6. So what would you do in a situation like this? Well, One option was to think about doing a 2-level revision corpectomy through the OPLL. I thought about it, but it could get a little messy. It's a revision, pretty bad OPLL. And of course, by itself, doing that wouldn't treat the deformity, right? It may treat some of the neurologic symptoms, but you still got stuff going on at T1, T2, and the overall chin near chest type presentation. So what I did instead was a T1 pedicle subtraction osteotomy combined with a revision laminectomy at the upper cervical levels. And the idea was that by correcting the alignment, you can get some indirect ventral decompression at that C3-4 level away from the OPLL, and at the same time directly relieve the compression that was there at T1, T2. So this is the postoperative scan. You can see the wedge that's been created at T1, about 32 degrees. Again, you're typically going to get around 30 to 40 degrees. And in terms of her outcomes, she did very well. Her preoperative neck and arm pain was completely gone. Her myelopathy improved significantly, and you can see her cervical sagittal balance is much better. Her chin is now way off of her chest. And interestingly, you can see how even the thoracic and lumbar spine changes as a result of that compression. So this is something that we can do in the lab today as well, and so I look forward to working on that with you guys. Thank you.
Any questions for Dre?
How many levels down did you fuse from PSO?
On that case? I think I fused 3 levels down, but the part, I didn't have time to go over all of this, but she had thoracic autofusions. So I love seeing that, because then you know you're not going to get PJK or DJK, because it's got like a nice transition zone. So in any kind of deformity, if you can park your fusion next to an area that's auto-fused, hopefully a couple levels that have been auto-fused, it's like a nice smooth transition zone, and I see a lot less PJK and failure in those kind of cases.
I know the CT and MRI are going to tell you about CT in terms of what levels are fused or not, but have you ever had a patient that once you put them on the table, they go to sleep by anesthesia, you see that they actually can relax and they get much more extension and they're not fixed kyphotically? Has that ever changed your plan when you see that right before starting?
Yeah, I mean, usually though with PSOs, you're going to do it in people who are fused, right? Where a good part of the spine is already fused and you can't get enough correction through the available motion segments above or below. To get a better assessment of general flexibility in the average deformity patient who may not be fused, I actually find that comparing the upright images to the MRI or the CT scan is more helpful than getting flexion extension.